Dr. Pearlz clinical rounds here with the case on acute otitis externa. Let's get right into it. 15-year-old female presents with the complaint of right-sided ear pain for the past 2 days. Patient reports a sensation of fullness and intermittent sharp pain that is worsening. Patient reports clear discharge from the right ear. Patient reports regular Q-tip use and has been swimming in the pool regularly. She denies hearing loss, tinnitus, dizziness, fever, or chills. Patient has not tried taking any medications and denies recent ear infections. Patient has no significant past medical history and has no known drug allergies. Remember to ask pertinent review system questions such as ear pain, hearing loss, dizziness, tinnitus, discharge, and pruritus. History should be targeted to ask about water exposure, recent ear infections, self-instrumentation, tympanostomy tubes, known tympanic membrane perforation, hearing aid use, prior ear surgery, or history of radiation therapy, or chronic skin conditions such as eczema. Vital signs are normal, and on exam, patient has pain with palpation over the tragus on the right side. Ear exam on the right is significant for a diffusely erythematous ear canal. The tympanic membrane is intact and is without erythema or effusions. There is no apparent discharge or evidence of any foreign bodies. First, examine the outer ear for any abnormal swelling, redness, discharge, or vesicles. When performing the ear exam, gently pull on the pinna and push on the tragus. Tenderness may be elicited if there is an infection. Remember to examine the normal ear first as to avoid spreading infection via the ear speculum. Be gentle and take care not to insert the speculum in too deep, which will cause discomfort. Examine the canal and make sure to evaluate for canal erythema and edema. Also look for cerumen impaction, foreign body, tympanic membrane rupture, or the presence of tympanostomy tubes. AOE may also be present with an erythematous TM, and it may be helpful if pneumatic otoscopy is used to help differentiate acute otitis externa from acute otitis media. AOE will have good TM mobility, while AOM will have absent or limited mobility. This is because AOM will typically have middle ear effusions, which is not present in isolated AOE. Based on the patient's history and exam, the patient has acute otitis externa. So what is acute otitis externa? Acute otitis externa is also known as swimmer's ear. It's defined by the AAO-HNS as a diffuse inflammation of the external ear canal, which may also involve the pinna or tympanic membrane. It is a cellulitis of the ear canal and subdermis. It usually occurs when there has been a breakdown in the skin cerumen barrier, which can lead to bacterial infiltration. It is most common in summer months, and in North America, approximately 98% of cases are estimated to be from bacterial causes. Most common bacterial causes are from Pseudomonas aeruginosa, Staphylococcus aureus, and Staphylococcus epidermidis. Other gram-positive and gram-negative organisms can cause AOE. Fungal otitis externa is uncommon but may occur in chronic otitis externa or after treatment with topical or systemic antibiotics. What is the etiology of an AOE? Etiology is multifactorial and could be from the following: water exposure from swimming, increased humidity, or warmer climates. Regular cleaning of ear canal can remove cerumen, which acts as a barrier to moisture and infection. Debris from dermatologic conditions such as eczema, psoriasis, and seborrhea. Secondary to a cerumen impaction, foreign body, dermoid cyst, sebaceous cyst, or a furuncle. Local trauma from self-cleaning, irrigation, or wearing hearing aids. Sweating, allergy, stress, or it could be from anatomic, narrow canal, or exostosis. So how do you diagnose an acute otitis externa? AAO-HNS guideline targets 2 years and older and excludes any age with chronic or malignant otitis externa. As per the guideline, a diagnosis can be made when there is rapid onset within 48 hours in the past 3 weeks, and symptoms of ear inflammation such as otalgia, itching, or fullness, with or without hearing loss or jaw pain, and signs of ear canal inflammation such as tenderness of tragus, pinna, or both. or diffuse ear canal edema, erythema, or both, with or without otorrhea, regional lymphadenitis, tympanic membrane erythema, or cellulitis of the pinna and adjacent skin. It is important to distinguish AOE from other causes of otalgia, otorrhea, and inflammation of the external ear canal. Differential diagnosis should include furunculosis, or infected hair follicle, viral infections such as VZV, causing Ramsay-Hunt syndrome, or HSV, contact dermatitis, eczema or psoriasis, TMJ syndrome, which is the most common cause of referred otalgia, cholesteatoma, which requires an ENT referral, otomycosis, foreign body, or acute otitis media. What is a potentially fatal complication of AOE? It is important to rule out malignant external otitis, or necrotizing external otitis. This is an infection of the external auditory canal that has spread to the base of the skull. Suspect in older adults who are diabetic and or immunocompromised, who have severe otalgia and otorrhea with pain out of proportion to exam, or a classic finding of granulation tissue at the bony cartilaginous junction of the ear canal floor, edema, erythema, frank necrosis of the ear canal skin, or cranial nerve palsies, which is a poor prognostic sign. These patients should be referred to an inpatient setting or an ENT for further evaluation and higher level of care. What factors may modify treatment? Non-intact TM, tympanostomy tubes, diabetes, immunocompromise, prior radiotherapy will affect the recommended treatment. What is the management for acute otitis externa? If the tympanic membrane is intact and there are no tympanostomy tubes, a topical antimicrobial agent is a first line. Acetic acid, with or without hydrocortisone, neomycin polymyxin B hydrocortisone combo, ciprofloxacin, or ciprofloxacin dexamethasone or ciprofloxacin hydrocortisone may be used. There is no evidence that one agent is superior to another. However, cost may be a factor, and generally neomycin polymyxin B hydrocortisone is the most affordable medication. If there is perforation of the tympanic membrane, known or suspected, or tympanostomy tubes are present, aminoglycosides such as neomycin, or acidifying agents such as acetic acid, or agents that contain alcohol must be avoided as they can be ototoxic. Fluoroquinolone topical antibiotics such as ofloxacin or ciprofloxacin, with or without dexamethasone or hydrocortisone, may be used. Neomycin may cause permanent sensorineural hearing loss due to cochlear damage. If there is canal obstruction, such as cerumen impaction or inflammatory debris, oral toilet should be performed. Use body temperature water or 1:1 body temperature water and hydrogen peroxide mixture or saline solution to gently lavage. If there is significant swelling of the ear canal, or if most of the tympanic membrane cannot be visualized, an ear wig can be placed to enhance delivery of the medication. The wig may fall out spontaneously, or the patient can follow up for removal. If the swelling is severe and topical agent cannot be administered, or ear wig cannot be applied, or oral toilet cannot be performed, or there are contraindications to topical agents, an oral antibiotic should be considered. Oral antibiotics such as levofloxacin will have pseudomonal coverage. However, if this cannot be used, amoxicillin clavulanate can be considered. If there is evidence of cellulitis that extends beyond the ear canal, pinna, skin of the neck, face, deeper tissue, the patient is a diabetic or is immunocompromised, both topical and oral systemic antibiotics should be used. Or, if you suspect otitis media along with otitis externa, you can use topical and oral. In general, oral antibiotics are not recommended for treatment of AOE unless risk factors are present. For pain, acetaminophen or NSAIDs on a scheduled regimen may be considered. Topical antimicrobials should be used for a minimum of 7 days. In our patient, as there are no risk factors for severe illness, any topical antimicrobial agent can be used. Neomycin polymyxin B hydrocortisone is most likely the most affordable choice and can be considered. Follow-up. If the patient fails to respond to initial therapy within 48 to 72 hours, reassess to confirm the diagnosis of acute otitis externa and exclude other causes of illness. Swimming or other water sports should be avoided during treatment. Tips for prevention include removing obstructing cerumen if possible, using acidifying ear drops before or after swimming, drying the ear canal with a hair dryer on the lowest heat setting, using earplugs while swimming, using earplugs or cotton cover with petroleum jelly while showering, avoiding the use of Q-tips can help with prevention. That's it for today. Thank you for watching Dr. Pearl's Clinical Rounds. If you enjoyed the video, please hit the like and subscribe button. Let's move on to the next case.